Okay, Paul, we're good to go.
Good afternoon and welcome. My name is Paul Boateng, and I am moderating this fourth and final event in the series COVID-19 Exchange, brought to you by BOBAB and Medicus. And we'll be hearing more about BOBAB and Medicus from Nick State and Jean Kayula in a moment. But today we're looking at the issue of the economic consequences of the pandemic in terms of healthcare, paying for healthcare. We're looking at how we manage the cost to individuals, to organizations, to nations, and how particularly we manage that cost and generate new funding in a way that protects the most vulnerable. What's characterized these last three seminars in the course of this series has been the focus that we will continue to have in this fourth on the practical. What can we do to make a difference? What can Africa add to its own solutions to the challenges that it faces? But also, and importantly, what can Africa add to the global response to this pandemic? But Africa has its own unique context for this discussion about financing and resources. Africa makes up 16% of the world's population, carries 23% of the global disease burden, and yet accounts for only 1% of total global health expenditure. So the reality is, and this is the context for this important discussion, that the rest of the world spends 10 times more on healthcare than Africa. Africa faces also the grim reality that it has not yet been able to meet the commitment made at Abuja by all African heads of government that their countries would spend 15% of their total budgets on healthcare. That simply isn't happening. The reality is that 37% of all Africa's healthcare spending comes from out-of-pocket payments. So it's individual Africans who have to bear so much of the burden of their own healthcare costs. And at a time of this pandemic, the reality is that that's putting an intolerable burden on already stretched budgets. We couldn't be more fortunate in terms of the lineup of speakers that we have today. And I'll be introducing them in a moment. But before I do, I'm going to ask Nick State and Jean Kayula to tell you something about BOBAB and Medicus. So over to you, Nick.
Thank you, Paul. Thank you very much indeed. And thank you everyone for taking the time to participate today. It's great to have you with us. As a quick introduction, as Paul mentioned, my name is Nick State. I'm the CEO of BOBAB. We are an event streaming and peer-to-peer networking platform dedicated to connecting science, tech, and business professionals working in and for Africa. Our work is guided by a simple belief that complex, multifaceted problems and challenges and opportunities that many countries in Africa face addressing them will require unprecedented levels of collaboration between the private sector, between academia, between policy, and indeed the third sector. So we've built a platform that we hope makes it easier for all those different parties to come together, to galvanize, connect and collaborate around issues that they're passionate about, issues that are important. And of course, healthcare finances, the focus of today, is certainly up there. We're really, really delighted to be co-producing this series with the guys from Medicus. Jean, of course, will provide some more information on them, but I know that they're doing an awful lot of good work on the ground in Africa, particularly in Kenya, connecting medics and facilitating knowledge sharing, which in context of COVID-19, sharing accurate knowledge well has become incredibly important. So we're delighted to be partnering with them today. And yes, this is the fourth and final event in the COVID-19 Exchange series. We've had an absolutely fantastic response. A great chair, thank you, Paul, so far, some great speakers and some absolutely wonderful participants who've not held back in terms of contributing what they think, what they feel, and we encourage you all to do that today. One thing, because this is the last event of this series, I wanted to mention that it won't be the last event that we'll be doing. We'll be designing and collaborating with other partners to host additional webinar series. So I hope you'll be able to participate in those. And the other thing to stress, again, as this is the last one in the series, is please don't let this be the end of your contribution to the discussion. Don't let this event, and whether you ask a question today or you don't, be the last time you interact with this discussion. We've got a fantastic group of people together. They're all profiled and accessible on the BOBAB platform. There's been some wonderful projects posted on our interactive projects map. So I implore you not to let this be the last time you engage with this really, really important theme, and help us and help you connect with people you want to connect with, and you can do that all via the BOBAB platform. So yeah, delighted with the series so far, and really looking forward to another really interesting discussion. Thank you.
Thank you very much indeed, Nick. Jean Kaula, over to you from Medicus.
Thank you, Paul. Yes, just as Nick has said, you've been a fantastic chair. Thank you so much. I really enjoyed these sessions. Just as Paul has said, my name is Jean Kaula. I'm the Business Development Director at Medixus, and at Medixus, we're all about knowledge sharing. And part of what this has been in this webinar series is bringing together experts, bringing together people so we can learn from each other. We started the journey with experience sharing. We heard from the UK, the US, here from Kenya, perspective from Ghana, doctors just sharing about their journey and experiences. We touched on mental health implications. What does that mean for healthcare workers? What does that mean for patients and the public at large? And last week, we were looking at how do you continue care amidst a pandemic? How do you ensure that you still have good quality care? And how do you keep your staff and your patients safe? And today, we're really excited to be looking at the financial implications. It's something that's been so heavy on people's minds and hearts. And, we've got a great lineup of speakers there for you. And in line with the financial implications, at Medixus, we realize that the challenges that health facilities especially are facing at this time. So part of our support has been giving up our Medixus Enterprise platform for a period of 3 months for free. So for facilities that are willing to take that up, we're partnering with them. We've got some facilities we're working with here in Kenya just to do that. So yes, do reach out. As Nick has said, this is not the end of the conversation, even though the webinar series is ending today. Hopefully it is the start of the conversations going forward. When we're putting together this webinar series, it was how do we go beyond just talk? How do we move into action? And so I'm looking forward to seeing a lot more of that. And so welcome to everybody. Back to you, Paul.
Thank you very much indeed, Jean, and thank you for your contribution throughout this series. Our first speaker is Agnes Gitter. Agnes is an experienced trade and investment advisor with GBS Africa. Her role is in advising businesses on managing political and policy risks associated with investing in sub-Saharan Africa. But she brings to the job a range, and to our discussion today, importantly, a range of experience, not least working with East Africa Economic Chamber of Commerce, with a particular focus on Middle East, European, and North American markets. She recently joined the Board of Trustees of Five Talents UK. She sits on numerous bodies, Legal and Business Women's Network, ICSA, the EAIAC, East Africa International Arbitration Conference. So it's a wealth of experience. A number of you may have seen her in contributions to debates on the BBC, Al Jazeera, Reuters, Bloomberg, and others. A wealth of experience about the practical day-to-day challenges of investment in Africa in healthcare financing. So we're looking forward enormously, Agnes, to your contribution. Just a word for all of you. This is a conversation, as both Nick and Jean have stressed. So there'll be an opportunity after each speaker for a couple of questions. And at the end, we'll have a broader discussion about the topic of today's presentation. So over to you, Agnes. And everyone, please mute your microphones except for Agnes. Thank you.
Thank you very much, Paul, Nick, and Killer for this opportunity. Paul, you forgot to add that in the last 3 months, I've become the head teacher in my house due to the fact that I'm now homeschooling. And so, but thank you very much. Back in December, when we started this conversation, Nick, we talked about the challenges that Africa faces when it comes to financing healthcare. We didn't know then that in about a matter of weeks that we'll be facing a pandemic that has just distorted the whole the global economy. And we're here now yet again to discuss and try and find solutions as to how we can work together, both government and private sector, to rally financing into the healthcare sector. And Paul, thank you for really starting the conversation, bringing into the context the environment, the current environment in regards to financing in the continent. So today I'll be talking about the financing pandemic, looking at who should pay for it. Should we be paying for it? Should governments be paying for it? Or should individuals, should insurance companies pay for it? And my starting words really, and if you let me, Paul, maybe to bring into context, there's been a lot of talk about how Africa has handled this pandemic, perhaps better if you compare it to the developed economies. And I found that really patronizing. To date, we have about 4,000 deaths and about 152,000 cases. Northern part of Africa and Southern Africa have reported the highest rates of fatality and infection. And so Africa, most of Africa, they're patting themselves on the back saying, look, we've done better if you compare it to developed economies. And I'm here to say that, no, there isn't time to celebrate. We've had a lot of time, we've had a lot of opportunities, and one death is one too many to celebrate. So going forward, yes, there's been some decisive action from the policymakers in regards to how they work together to curb and control the spread of the pandemic. But it's not time to celebrate. There is a lot of challenges. You highlighted the deficit, the financing deficit in the continent is about $66 billion. And these are figures that have been going in and out. You talked about the commitment that African heads of state back in 2001 committed to contribute at least 15% of their budget towards financing Africa's healthcare. To date, only Rwanda, and Rwanda gets mentioned in a lot of these places, only Rwanda that spends at least 20% of its budget on its healthcare. And you can see how successful Rwanda is doing. And you know why? Because I think the leadership in that country understand that a healthy nation means a prosperous nation. And also they've come up with a lot of innovative ways, bringing in private sector. And only yesterday, a healthcare company, a medical company from South Africa was able to cross-list in Kigali, Rwanda Stock Exchange. So you can see innovation. And they were asked, why Rwanda? They talked about innovation, incentives, and efficiency of government. So there is a lot of conversation going on. If we are going to attract private sector, we need to do a lot more. But I wanted to share that just for the sake of really bringing things into perspective, that yes, this is where we are, this is what we've done, but there is a lot more. My starting point, I hope you can all see my screen. And I think in relation to what I've said about Rwanda, I think it's important that a good health financing system must be able to be able to raise funds so that every citizen is covered and that they're protected from financial crises associated with out of payment that you talked about, Paul. And who finances pandemic? What is the situation at the moment in the continent? Everywhere, governments have a mandate, particularly through the Public Health Act, to control and respond to pandemics, COVID-19 being one of them. To date, the World Bank estimates that Africa will need to spend at least 1.5 to 3% of their GDP to finance and respond to pandemic outbreak. We already have other competing priorities, and these will obviously be so stressful for the continent. The Economic Commission for Africa earlier last month shared a report saying that we needed at least $23 billion to prepare and be able to treat COVID-19 in the continent. They also talked about another $53 billion, assuming that the pandemic spread to affect about 720 million people. Luckily, we haven't reached that yet, and we do hope that we don't have to be there. But an estimated $100 billion is required to respond to COVID-19. Remember, 5 years ago, we talked about that the financing gap already was 66 billion. Now we need another 100 billion to be able to combat COVID-19. Where will that money come from? It's financing opportunities you alluded to is already very difficult for African government to access finance, affordable finance from everywhere. So we really need to work together with private sector to find ways of how we can be able to address this gap. I wanted to share, and I was having this conversation earlier with Nick, that yes, there have been solutions by World Bank, the World Health Organization, or we call them the Beggable West. And in 2016, in response to Ebola, they created a pandemic emergency finance, a 500 million pandemic emergency finance. And this was to support African countries or poor countries to be able to deal with the pandemic. The irony of this is that you can only be able to trigger payment only if World Health Organization declares it as a pandemic. We are aware that it took a while for WHO to declare COVID-19 as a pandemic. And so there's been complications about this. Yes, there are solutions, but these solutions are so complicated that they fail to address what they actually meant to be there for. And to date, I think about $20 million have been paid out. That was for Ebola. But the other story I was sharing with Nick is that the investors into this bond have made more money than the countries that are supposed to be able to benefit. So there is, I mean, you say capital is competitive and private sector is innovative and they want to make money. A conversation about moral money, responsible capitalism has come up as a result of this pandemic. And I'm sure Gita will probably share with us about impact investing and social responsible investing. So there are solutions, but coming from private sector, these solutions must be able to address the challenges. And I know we, our shareholders always, of course, demand profit. But I think profit, we have to question, should it be at a cost of someone else's life? So yes, come up with innovative solutions, but those solutions must be able to address the challenges we face in terms of healthcare. So who should pay for pandemics? Should we pay for it, or should governments? Or should insurance companies pay for it? Well, there was some conversation when this started early in February, whether insurance companies, and there was a bit of confusion who should pay for it. Insurance companies in Kenya initially said a pandemic was an act of God, so therefore it was an exclusion. But I am very happy to share development from Kenya and Southern and Eastern Africa that insurance companies have been given a directive through the regulatory bodies and they've been advised that they must be able to meet and pay for the claims, healthcare claims. And when you talk about why I have insisted on the importance of financing healthcare so that it's affordable for everybody, not just those who can afford private insurance, we already know that the penetration is already very low with South Africa and Kenya leading. So when we think about private insurance, it's mostly for people who are in employment. Over 60% of Africans are in informal sector. So therefore, they cannot afford any health insurance. And as we talk about whether medical insurance companies should be paying for it, I'm just really thinking about, what about the bottom billion? What about those people who cannot afford insurance? Who do they go to? These, again, provides an opportunity for microfinance for the less affluent people. How can private sector find an opportunity to provide insurance cover for those people who are not in employment and where government is not able to? So I spoke about the guidelines by the insurance regulatory in Kenya and the health insurance, Association of Health Insurance in South and Eastern Africa, where they have advised their members that, and those are some of the guidelines, that in case of a pandemic, they should be able to honor and honor payments. And also, more importantly, they must also be able to protect and pay and protect the agents who go out there working for them. So what are the opportunities? I work in an environment where I always have to provide an opportunity for investors. Again, and as both Kenya and Southern Africa insurance have shown, I think insurance companies, there is a saying that insurance organizations give you an umbrella, and when it starts raining, they take that away. I think this is an opportunity for insurance companies to be a force of good and to restore the confidence of the society and support this pandemic, because it has hit everybody. We shouldn't be all about profit. They should be empathetic and also work closely with the governments to support everybody during this crisis. What is the future? What is the future of Africa's healthcare post the pandemic? The continent, I'll give you an example. South Sudan, one of the youngest member of the African Union, has more vice president than ventilators. The country has 10 vice presidents and has only 5 ventilators. We really need to do much more and invest in our screening capacity of infectious diseases. I think we learned, some of the countries, particularly in the western part of Africa, learned from Ebola to start screening, and I think that has helped us. We also need to work closely with insurance companies to modify policies so that we can cover those that are affected by the pandemic. A lot of these I'll say my wishful thinking. I do wish that some of these guidelines or some of these suggestions that some of our policymakers may take them on board. And this is not something that started today. This is something that we talked about in 2016. We've continually talked about this is what we need to do. So policymakers know it's not rocket science. They know what is required. We talk about growing our economies. I'm going to stress, if we have to achieve those economic targets, we really have to invest in our health, in our health sector. Again, the World Organization estimates that you only need $2.5 to $3.5 per person to be able to respond to a pandemic. Just imagine how much money is that. It's a coffee doesn't cost probably much more in Starbucks than $3.5. So if governments was really willing and were able to manage the resources they already have, we could be able to have enough money so we don't have to always come begging when a pandemic like this happens. So regulatory framework. There's been a lot of red tape in procurement on who does what. We really need to have a framework, that gives incentive for private sector to come on board, but also makes it easy. So when a pandemic happens, there's a system for us to be able to work together and address what is needed in the society. Again, I can't say it enough, but how can we make finances available? And I think when I say make finance available to health facilities and avoid mismanagement of resources, we need to find innovation. Paul, you alluded to the fact that it's already difficult for African governments to access finance. We're already heavily in debt. In the last 3 months, over $10 billion has been deployed in loans to the African government to be able to respond to this crisis. Will these funds be directed to healthcare? We don't know. So if we are not able to manage our resources properly, come up with innovative solutions, find ways of financing our health system. How? I have a suggestion. How about diaspora remittance? $48 billion annually is remitted by Africans in the diaspora. This money usually goes toward education and healthcare. How can private, and Gita, I look at you when I say this, how can private sector rally this capital to be able to channel it to healthcare? Because we already send money to pay for our relatives to go to hospital. Imagine if this was channeled to building a healthcare infrastructure. I'm sure we'll all be having a different story today. So Paul, really to close, I will repeat what you say, that we should commit to the 15% commitment to financing our healthcare budget. These African government committed to it. Again, only one country in Africa, 20% of its budget goes to healthcare, and that is Rwanda. And you can see the differences. So if we commit 15%, government commits 15% of its budget to healthcare, then the private sector, Gita and I and all others, will be able to fill the remaining gap. And that's my 10 minutes, Paul.
Thank you very much indeed for that, Agnes. A voice from the front line of raising capital, finance and investment for the continent, as well as, you say, a part-time headmistress in her own home school. So thank you for that. And now, are there any, I'm just looking at the chat session. Are there any questions that have come up from our participants? Because now is the time.
No
yes,
questions.
Tony. I beg your pardon?
Oh, sorry, Paul, go on.
Did I sense you had a question, or were you just moving forward expectantly?
No, moving forward expectantly. Well, let's hear from Tony.
Tony.
No, actually, I was leaning forward to see if there were any chat messages, but I don't have a ready question. But I just want to say how interesting that was. That was the first time when Agnes spoke that I've heard the global picture. It's always been microfinance projects, which I commend, but it was very good to see the whole picture. So thank you, Agnes.
Thank you very much for that.
Yeah, okay.
I've got a question on this. There's one coming up on chat, and you'll tell us if there is, Nick. Agnes, we've heard a lot of talk in the past few weeks about potential initiatives emanating from the UK, supported by government, to encourage the UK private sector to involve itself in opportunities for healthcare provision and investment in Africa. Has any of this actually made any difference to you in your work in the city? Because I know there's a lot of chat in government circles about it. I'm just wondering whether it's actually percolated down to the front line, which is where you work in the City of London.
So Sunday, there's been some deals in the last 5 months, in the last sort of 3 months. I guess the conversation started way before COVID-19, and these are directly gone into healthcare. And I'm sure you know already in this platform, we have Ilaro Health, which is a fund, a healthcare company in Nairobi, got some funding from some UK and some from the US. And also there's another digital company really all focused on healthcare. Investors are worldwide, they're not just from the UK, but there's been a push led by the Department of International Trade, really pushing UK private sector to put money in Africa's sector. But you need to do much more. I think we need to see government supporting UK private sector, working with them closely, providing even finance so that they're able to support or invest in that. But there's been some deals. They say never waste a crisis. We've seen some very innovative e-health deals that have sort of closed in the last 5 months, and most of them are in South Africa and Kenya, and all are related to the healthcare sector.
Thank you very much indeed. And we've got a comment coming in from Mariama Kamara, and she makes an important point about what can we in Africa do to promote and encourage innovative ways of financing from local sources. I mean, we hear a lot about finance coming externally, whether it's from the West or from the East. What can we do at home to change the mindsets that all too often our would-be investors would rather invest outside the continent than in it, and certainly aren't taking innovative steps and applying their considerable skills to innovative financing on the continent itself. Any comment on that, Agnes?
Yes, thank you very much, Mariama. There is already a lot of local investors who invest in local companies. A good example is within the East African space and South African space. We've also seen a lot of South Africa funds getting into East African region. We've seen Nigerian company investing in East Africa. So there is already that movement of regional investors investing in the continent itself. I talked about diaspora. Diasporas are local Africans working abroad, 48 billion domestic capital lying there. So this money, we need to find innovative ways because they send it for healthcare. How can we now then use that to channel to innovative sectors? But you're right, there is already, I talk from an East Africa's perspective, there's already confidence in our market. I think East Africa has shown that they already have a confidence in our market. And so therefore, I hope that works to encourage other would-be investors to come into our region.
Thank you very much for that, Agnes. And an important point too about the diaspora, who are, after all, recognized by the African Union as a constituent part of the AU. So we ought to factor them more into our thinking in terms of innovative finance mechanisms. It's now my pleasure to turn to a voice from Kenya, again, very much on the front line, a consultant obstetrician, gynecologist, Dr. Njoki Fernandez, but speaks to us not only with that medical background at the highest level, but also, and importantly, for today's subject matter, as chair of the Healthcare Finance Committee of the Kenya Healthcare Federation, which a number of you will know, a private sector membership-based organization that serves as the health sector board of the Kenya Private Sector Alliance, with 160 organizations represented on that body, giving a voice to the private sector in policy making in Kenya. So we look forward enormously, Dr. Fernandez, to your contribution. Over to you.
Good afternoon, ladies and gentlemen, and thank you for your kind words of introduction. As usual, I will always struggle to share my screen. It's one of those. And
also, you're quite soft.
Oh, I'm sorry.
Njoki.
Is that better?
That's much better. Thank you very much.
Okay, all right. So I'm still learning how to share screens.
Aren't we all?
All right. Okay, here goes, if I can find it. Oh dear. Just give me 1 second and I'll figure it out. No problem.
At the moment, we're looking at a very calming lake scene.
That's not what you're supposed to be seeing.
I guess not, particularly as it looks more like Alaska than Kenya, but there you are.
This is not even funny. Okay, let me try that again. I'm so embarrassed. Okay.
Dr. Fernandez, would you like me to share the screen for you so that you can see?
I think that would help.
Great, that'd be a good idea.
No problem. Bear with me 1 second.
Sorry, I haven't learned how to do this.
No problem at all, because we're all familiar with this issue. Great, it's coming up very clearly, Dr. Fernandez. We can see it.
Okay, so Nick can help me. All right, so brief introduction, like you heard, my name is Dr. Njoki. I'm an obstetrician by training, but have quickly morphed into the role of healthcare financing, which I find very, very interesting and also impactful to the private sector situation in the country. I chair the Healthcare Financing Committee at the Kenya.
If you'd speak into the microphone, Dr. Fernandez, please.
Okay, like that?
That's great.
Is that okay? Okay, all right. So I chair the Healthcare Financing Committee at the Kenya Healthcare Federation, and I wanted to share some ideas on how we can finance pandemics at an individual level and at a corporate level. Agnes has gone all global and government, but sometimes it boils down to you and me. What can we do as individuals and as institutions to make sure that we can handle this situation and whichever other will come. We'll appreciate that this pandemic situation is new to all of us. We were not here during the bubonic plague or, you know, all those other things we hear about. So it's new for all of us. But I think moving forward, there are lessons that we can learn. Maybe we can move on. And I want to paint a picture of the healthcare situation that we have. Probably you've heard these things before, but it's important to realize that in Kenya especially, the sector that COVID-19 is a healthcare pandemic, but the healthcare system in Kenya is collapsing, which doesn't make sense because we thought we'd be overwhelmed. We thought we would not have space in our beds, we'd have no capacity in our hospitals, but our hospitals are empty, which doesn't make sense. I think this COVID has treated us abnormally, as our CS likes to say. So just to paint a picture of what has happened is that globally, we've had healthcare systems being overwhelmed, including advanced systems in the first world. We've seen what has happened in the US, in Italy, in Germany. You know, the economies that really are the leaders in healthcare, they have not managed the pandemic as far as their countries have been concerned. And when we looked at that, we sort of anticipated that this would be the situation at home. And thanks be to God, in 30 years, we will figure out why it hasn't happened. We don't have answers, but it hasn't, and we're grateful for that. So globally, the systems have been overwhelmed. In this country, we have so much capacity that is unutilized. And then also what has happened is that the traditional manufacturers of healthcare items were unable to cope because the global supply chain was also overwhelmed. Everyone wants PPEs, so we can't get what we need. And the biggest supplier, which traditionally has been China, also had problems of their own. So that was another problem. And then because of that, we started getting substandard and poor quality items flooding the markets. There was no time for quality control. And I don't know whether you saw in this country when we started making sanitizers, everyone was very excited doing their own thing. And what did we see? People started getting reactions, their hands, because the chemicals were harsh. There was no time for proper quality control. And then we saw fake masks that were not 3-ply. They were actually dangerous. So by the time we figured that out, some time had gone. And like I said, because the hospitals are empty, the capacity that we have for other treatments, for other diseases are sitting there. Idle capacity in infrastructure, equipment, and human resource. Okay. So, ironically, in this country, the human resource for health are facing job losses and salary cuts. Ironically, we've seen hospitals posting that they're giving their hospital workers pay cuts and they're actually retrenching. We're in a pandemic, but hospitals are sending their staff home. It is ironical, yeah, because we need them the most, but somehow we don't have the money to pay them. And then the issue of exposure to the risk of infection because of lack of adequate support with equipment, finances, and with moral support, our frontline workers are still exposed to high risk. Okay. So, like I said, the hospital providers are facing an imminent financial crisis due to a severe dip in revenue from elective procedures and clinics. At the beginning of the pandemic, our Director General sent a notice to all the hospitals telling them to suspend elective surgeries and elective clinics. And you realize that these non-emergency procedures are the bread and butter of every hospital. So when they don't come, they stayed away, the hospital's revenue dropped by more than 50%. That is one problem. The other problem is that especially for patients with chronic disease, non-communicable disease, hypertension, diabetes, asthma, etc., then their treatments were not being given to them. So they stayed at home because we're all afraid of getting sick. And they only present to hospital when they're very sick in emergency conditions, which is not ideal. So there was this impression that we're all going to get COVID if we go to hospital. So we all stayed at home. Antenatal care dipped, children stopped going for vaccination, things like that. Another problem is that providers, wait, sorry, Nick, not yet. Providers are facing a severe cash flow crisis due to crippling debt from debtors, NHIF, private insurers, and other payers. There is no money to pay. It's not a priority. And then the last thing is that the escalated cost of supplies because of unreliable delivery and quality and very unfriendly purchase terms. Everyone wants their money upfront. They want it now. And the providers don't have this money. So it's expensive to manage this situation. Okay. So, of course, we don't have enough investment in education and research so that we can better understand the disease and its various manifestations and improve our treatment methods. And communication, consultation, and synergy, both locally and internationally, are lacking. Everyone is basically struggling to do their own thing the best way they know how. We don't even talk to our neighbors, so we don't know why Tanzania is opening up schools next week. What's the magic bullet? What are they thinking? I wish we were having some communication. It would help us resolve our confusion, but we're not talking to each other. Yeah, okay. So when we are funding pandemics, there are two costs that we have to think about. There's the cost of saving life, and that is the healthcare cost. And what does that cost go to? Testing, quarantine, and other containment measures, treatment, the PPEs, the isolation wards, the ventilators, the medication, whatever equipment is required to treat the patients, and disposal of the deceased. Yeah, these are the costs as far as treating lives is concerned. Okay, and then the other cost that is probably what is biting us even more in Kenya at the moment, next slide, Nick, is the cost of livelihoods. Yeah, our bread today and tomorrow. And I've broken it down to bread because we are down to our bare minimum. We don't have money for butter and jam and bacon. You know, we are just bread, you know, basic. What is happening in all sectors, and especially in healthcare? We're having job losses, we're having pay cuts, we have seen loss of business revenue. We've seen hotels closing down, the major hotels. It's so sad that the Norfolk is no longer operating, and the Serena Hotel has shut down. And I'm sure if the big ones are closing, the small ones are also suffering more. And then we are seeing a situation where we have defaults of loans, mortgages, and rent defaulting. And remember, the person who's waiting for the loan to be paid, that is a loss of income to them. The person who doesn't get their mortgage repaid, the bank, is a loss of income to them. The landlord who doesn't get their rent paid is expecting that as income, so they suffer. And then, of course, like I have said, businesses are closing, which is a problem because of our livelihood tomorrow. We might live today, but if you don't have a job to go to tomorrow, it presents a problem. Yeah, okay. So what am I thinking? My suggestions are around being proactive as individuals and as corporations. It's very good to say what the government should do, what the World Health Organization should do, but we realize at the end of the day, we're on our own. It's up to us to think about how we can help ourselves and our people survive this pandemic and possibly prepare for the next one. Hopefully it doesn't come, but anyway. So prepare. Yeah. Number one, business continuity planning and risk management should take on a new meaning. Many companies do not take this seriously, but I'm hoping after this pandemic, now they realize the importance of risk management and preparing for the risk so that this doesn't happen in future. Many companies have contingency funds for catastrophic events, but on paper. When life is good, we find that, allow me to use this word, we're a bit wasteful. You know, we go for our strategic meetings to, I don't know, Malindi, we spend 5 days, we fly, I don't know to where, directors' expenses, we waste a lot of money. This is the time to realize that we can, this post-COVID, we don't have cash to waste. Why? Because unless your company can survive on operation expenses for 6 months without an income, then you're not in a good space. You need to make sure that you have enough funds to keep you going as an individual or as a company for 6 months without an extra source of income. And because of that, then we cannot afford to waste anymore, right? And then Another risk management thing is pandemic insurance. Agnes mentioned that many insurance companies are not willing to pay for the cost of treatment, but that's because they hadn't underwritten for it and they hadn't collected premium. Moving forward, it's a conversation you need to have with your underwriter for medical, for life, for WIBA, and for business losses. Let us put in pandemic insurance as part of our routine covers. Even if it means you have to pay a bit extra, it is absolutely worth it in the end. Okay. Excellent. I challenge Kenyan businesses to change our business model from credit payments to upfront payments and even advance payments. I'll probably get stoned for it. But in Kenya, we like the credit model very much. It's no longer sustainable because you were expecting to be paid in 60 days and then COVID happened. So 60 days will be 200 days. What happens? If at all you get paid. So now we have to think, secure your money upfront and before. So if you have a big client who you give credit, let them give you an advance payment, or like when you pay rent, you pay a deposit, isn't it? So that in case of default, you're able to invest that money. Yeah. Hospitals and healthcare providers should create an ex gratia fund that can easily be accessed, knowing that in pandemics and in any other medical emergency, there are patients who will not manage to pay for care. A patient will walk in and you cannot turn them away, but they cannot afford to pay for that care. Where does that money come from? So when you have an ex gratia fund, it's an expense to your account. It allows you to look after these people, and because you have provided for it, it doesn't mess you up so much. Yeah. And then we need to relook at our products, especially the service industry. And I was watching a documentary about Amazon, and Amazon have done so well, they're even reducing the amount of business they have online because they have figured out they can take the market to the people instead of the people coming to the shop. And they've done so well. It's groceries, it's food, it's electronics, it's everything. We have to stop sitting in our shops and in our hospitals and in our clinics and waiting for people to come. Take the product to the customer instead. Okay.
Thank you.
I think I'm on the last one. Wait, this is the last slide. To improve our operational efficiency, we have to outsource as much as possible. We're looking at our bottom line, yeah, to make sure that we have money to save for this fund that I talked about. Collaborations, partnerships, sharing of human resources, negotiating discounts with payers for prompt payments. And we also have to impose penalties for late payments, negotiating supplies again. And our customer service has to be on point because the customer will always come back to you even when times are tough. Okay, the last slide. Let's assess our business risk and decide which risks we retain and which ones we transfer to other risk bearers. The cost of risk transfer is always cheaper than the cost of bearing the losses. We don't have money, we don't have cash. So right now, if your car doesn't have insurance and it gets bashed, you have a problem because usually you'd have paid out of pocket, but now you're stuck. If you lose your phone, you drop it and the screen breaks. Before you'd have whipped out some money and replaced the screen, but now because we don't have cash, if you don't have insurance for that phone, you'll walk around with a broken screen or the phone may not even work. So let us do proper risk management so that we are able to deal with the crisis of funding that we have at the moment. And I think I'm done. Yeah.
Thank you very much indeed for that. Insightful and practical, and gives us a quite alarming view of the commercial impact of the pandemic on the health sector itself. I must admit, I hadn't realized the situation was so challenging to the private sector in Kenya. I've got one question while we're seeing if any others arrive on the chat line, and it's to what extent is government, the public sector, taking up the slack in the private sector during this period? So are you being, and your members, are you being used to assist in the testing function, in diagnostics? Are they making use of any of your empty beds? How is the public sector responding to the excess capacity that exists in the private sector, which must of itself reduce prices.
Okay. The interesting thing is that it's ironical because our beds are empty. There are no patients. You see, so if there had been a situation where the government hospitals were overwhelmed and they were spilling over to the private hospitals, that would be an issue. But even the government hospitals themselves are empty. At Kenyatta National Hospital, the last I checked, we're operating on 50 to 60 capacity, and Kenyatta Hospital is always 110% full, you see. So even their own hospitals are not full. So the private hospital tends to suffer that much. We're having a discussion this morning that the government should be able to absorb the private human resource that we have, you know, instead of allowing them to sit at home. But government is saying that we are dealing with our issues. So as private sector, you sort out your problems. And that's why I'm saying, actually, it's up to us. We have to figure ourselves out and prepare for the future because we're on our own. Yeah,
that's very helpful. Do I have any more questions?
We've just had a comment come through on the chat. Unfortunately, I don't know the person's name. It just says user. So you can identify yourself if you like. But they've said, I believe one of the costs associated with C-19 pandemic not mentioned so far is the cost of reintegrating the person in the treatment center and fighting the stigma associated with the pandemic in the community. Both of which has a big cost implication for the governments and partners in the fight. So I'm not sure, perhaps that person can elaborate, but is that around an education piece, perhaps?
Yeah, I mean, that's a good question. I mean, if fearfulness and rumor are keeping people away from hospitals, presumably that is driven by fear of the stigma attached to the condition, as well as the threat to life. What's being done to counter that view in the community by government or indeed by yourself?
I think in the private sector, they've been very open. We've even had videos and interviews of patients who have survived COVID-19. You've seen it on the media. And so just to encourage people that, you know what, I mean, life goes on. I was in ICU for 11 days and I beat the virus and I'm happy to go home. And I think what was driving the stigma was the initial drama around being arrested in curfew, being thrown into the treatment centers. I mean, it was like getting the disease was a punishment. But I think that has since changed now. And now that the government have said that they're going to pay for quarantine and the cost of treatment, we're finding more and more people coming forward to be tested. And the hope that after the 2 weeks, we are okay. They keep insisting we've had so many recoveries, because that is the truth. There is hope. It's not like HIV that once you get it, you're done, you know. It's a better disease because once you recover, then you're good to go.
Thank you very much for that. We've got a question which we'll come to later about the numbers of people being tested. But before we do that, our final panelist, Geeta Tharmaranatnam, brings 19 years worth of experience in private equity, venture capital, development finance, impact investing, and insurance in both Africa, Asia, Latin America, and indeed in Europe. She's CEO of Qualitas Capital Partners and leads their investment impact practice. So we couldn't have a more qualified contributor to this important area. She brings also, and importantly, her experience as a founding partner of T5 Africa Capital Partners and worked in the portfolio management team of the $1 billion global impact health fund of the Abraj group. So give us your take, if you would, Geeta, on the challenge, but also, and importantly, in your area, the opportunities that the current crisis presents. Over to you.
Thank you very much, Paul, and thank you, Agnes and Dr. Fernandez. You've all picked up on key points, and I'd like to try and integrate some of my thoughts on some of those points as I speak about the private financing of healthcare on the continent. You know, I didn't think this conversation could bring my experience together so clearly. The first part of my career is being spent in insurance and reinsurance, and the second part being spent in investments. And my career in investments started with what was Africa's first health fund. It was the world's first base of the pyramid fund. And I can tell you back in 2007, 2008, it was incredibly difficult to try and fundraise, to go out and convince investors, because private equity fund managers are managing capital on behalf of others. So you still need to convince the original investors of the viability of a market of investing in healthcare in Africa. And what was clear back then is as clear still now. It's in fact more pronounced. And a number of these statistics you have already mentioned, Paul. We know that predominantly the private sector in our countries in Africa are actually providing services to low and lower middle income consumers, because upper middle and high income consumers are leaving the continent for the most part for their healthcare, or they'll head down to Cape Town and roll this into a holiday at the same time. And what has happened now with the pandemic is, for the first time, people are realizing, I cannot get off the continent. I cannot go, quickly to Paris or to London or to New York or to Washington, or, as we've seen in recent years, flights going out into Thailand, going into India, right? The issue with us on the continent for so long, and it has hit many of us personally, has been the lack of access to affordable and quality healthcare. This is an issue now, it was an issue before, but I also feel that things have moved on and they needed to. So, over the course of the last 10 months or so, I've done something that I haven't done before. Before, I was working with fund managers and investing larger sums of money. In the last 10 months or so, I've also started investing my own personal capital into angel investments and into venture capital on the continent. And I have 10 transactions I've done in this time period. And this is, number one, the first thing that each of us can afford to do to some extent. So we're not talking about putting millions into a business. Sometimes it can be a couple of thousand. You get a few people together and these numbers start to make sense. And I'd like to mention two particular businesses, both of which are in the healthcare space. The first of which is called Life Stores. And Life Stores is a Nigerian pharmacy tech startup, which is disrupting primary healthcare. And they're doing this by addressing the inefficiencies in the entire value chain associated with small-scale chemists. And on the continent, as many of you know, a lot of healthcare is actually dispensed from pharmacies, not hospitals, not clinics, but pharmacies. I invested in this team and in this business because I really believe that if we're going to really disrupt the provision of healthcare, we need to take it outside of our hospitals. That has actually been a model that has helped in India to be able to get access to affordable healthcare, more integrated, moving it out of physical infrastructure into communities. And as we see a shift in the disease burdens, this is also important because you want people who now have life diseases to be able to handle this without needing to make those appointments and go longer distances to these extra facilities, as opposed to knowing there's a small clinic, a hub, a spoke, something in your neighborhood where you need to go in and get a diagnostic test done. And the other I just wanted to mention is 54 gene. Today, most of the genomic data used for development research is actually from Europe, the United Kingdom, and North America. So while Africa is actually the most genetically diverse place, African genomic data accounts for less than 3%. Less than 3% of the genomic data used for development research. 54 gene is trying to adjust that. So the reason I want to take a moment and just stress this is because that $66 billion deficit number when it comes to financing healthcare is so big, you can add another 5 zeros to it, and I would feel as helpless as I do when I'm faced with a $66 billion number. So I ask myself, what can I do? And what can people around me do? And how can we collaborate? And for me, that starts with, yes, we support our friends and our families and our communities, but now how do we ripple that out from a financing perspective, knowing that today, more so than ever in history, we have access to transactions, to businesses. Let's call them what they are. Transaction is just something, nuts and bolts. We have access to putting money behind entrepreneurs who are more visible now, who we can access more clearly now than ever before. So that's the first thing I think that really needs to make a difference. That first fund that I was a part of, we raised $105 million in 2008, 2009 to invest in affordable access to healthcare across the continent. Made about 11 investments, including 2 hospitals in Kenya, including investing in a syringe manufacturer in Mombasa, which took 3 years to get WHO certification. And once they did, were the only ones locally to be able to produce or to disable disposable syringes, which, by the way, the Kenyan government requires in its own health system. And they were able to drop the prices by a third. So the extent to which we are able to finance the manufacturing of healthcare disposables, all sorts of the elements of the healthcare ecosystem that we need to address, it makes a difference. Now, from a private equity perspective, and I'm just a bit mindful of time, so I'm going to move quite quickly. Please slow me down if there's something you want me to focus on. But from a private equity perspective, I'm quite unusual in many, many ways. Beginning with, I find it very ironic that government is always the backstop. Whichever country you're in, whichever side of that spectrum you thought you were before this pandemic hit, about whether I am capitalist, socialist, something in between. The reality now is everybody is turning around and saying the government is my backstop, right? The biggest organizations in the world, which have been very careful about tax planning, are turning around and saying the government is my backstop. We know this. And on our continent, we have got the lowest rate of tax collection. So from my perspective, anything government should be doing, take it as an equity stake. Because you know what you're doing? You are investing when government is coming to bail you out. And so when I look at this from a private equity perspective, just coming back into the industry slightly, I think this dynamic between public funding, private funding, and everything in between, impact investors, development funding, whether that is pure aid, which can go into the private sector or into the public sector. Because the thing about healthcare is it's a continuum of support that is provided. Primary healthcare is provided by the public sector because the cost structure of provision of primary healthcare makes it almost impossible for the private sector to provide. So you have the public sector, which is meant to provide primary healthcare at scale. It is considered a right in the same way that we consider it our right. Our governments provide us with access to primary education. And then it becomes a choice at which point individuals are going to the private sector, at least on the primary care side. But as you go into the secondary and the tertiary care side, more and more, it is the private sector which is bearing the brunt of that. And this private sector, when we look at it across Africa, with my experience of over 10 years, it is very fragmented. Getting to scale is incredibly hard because as we know in the individual choices that we make, when we're looking for doctors, when we're looking for nurses, when we're looking for healthcare professionals for ourselves and for our loved ones, we go looking for somebody who's vetted. So it's hard to scale a business which is independent of the reputations of those individuals within it. How do you take that one doctor and then scale up the reputation of that one doctor? It's very difficult. So getting that institutional structure in place, super important. But that said, one of my bugbears, of which I have a few, is between 2013 and 2018, of the capital that was raised in Africa, and that were in the private equity industry, that's been captured by the African Venture Capital and Private Equity Association. $17.8 billion was raised between 2013 and 2018. During that time, there were about 1,022 deals reportedly done in the private equity space. Do you know how much of that capital, by the way, went into healthcare? 3%.
Yeah.
3%. But that's also because back in 2008, 2009, when we started investing in healthcare in Africa, the businesses were small for the most part. The largest businesses were in North Africa and in South Africa. In between, you don't really have many hospitals which have much by way of scale. So part of the reason it's 3% is because there aren't large transactions to do. Another reason is also because it is much harder to invest in healthcare than almost any other sector, by my estimation, because you are dealing with so many factors to get to the success of this business over a longer time. And I call this a business because it is a business, but it's a business which has a obligation and a responsibility to its clients, its customers, its patients, which also far outweighs most other industries that are out there, most other sectors that are out there. And so when I look at the question of who should be funding, how should this be funded? We've had this discussion from 2013 about getting universal health coverage into our countries. Some countries are further ahead. And in Dr. Fernandez's presentation, I saw the reference to the NHIF. Ghana also is further ahead. When we talk about insurance, insurance provides us with that safety net. And there are plenty of examples going back hundreds of years, because the insurance industry is very old. Hundreds of years that shows when the private sector and the private insurance market is unable to really take the risk, right? Because what you don't want is insurance companies underwriting risk that they actually can't pay out. Because at that point, they go broke and there goes your coverage for everything else that they have covered. But there's precedents where government has stepped in to say, we will provide you with funding, which means that the calculation that you're doing to estimate what the cost of provision of this insurance for this thing now, which looks so bad that payment of this will cripple you, we will come and provide you with part of that funding. So then you have a shared model of public and private going into the building of that safety net. For me, that's a concrete example of what can be done to start building layers of those social safety nets. And when we talk about, who should this go towards? And starting off with the vulnerable. On the 20th of March, was maybe the 20th of May actually, the World Bank updated its calculations on the poverty rates around the world. There were 2 regions in the world where they said there was insufficient population coverage to be able to calculate this. One of that was Sub-Saharan Africa, and one of that was South Asia. The 2 regions of the world which we know have the highest concentration of those below the poverty line. We know this, right? So when we talk about the vulnerable now, what has become more clear, and this is not a philosophical point, what has become crystal clear, whether you are in New York on the Upper West Side, whether you are in Mayfair in London, whether you are in Muthaiga in Nairobi, wherever you are, our societies are as strong as the weakest person amongst us. So if we don't take care of the vulnerable, we might as well get used to the thought of being in lockdown or in and out of lockdown, as long as it takes for us to get vaccines, at which point we then pray that people will actually submit to taking the vaccines, which is a whole other discussion, right? Yeah. So when it comes to the financing piece here, I think there are probably 3 things that I would say. The first of which is insurance companies have an even more highlighted role to play now than they ever did before. I joined the insurance industry right after 9/11, and that was for me a very clear lesson on what the importance and the value of insurance is in our day-to-day lives. It is invisible, but it is strong. It is strong. So that is one important thing. And we saw the numbers there, the statistics there, in terms of how low insurance penetration is on the continent. We've known this. The number 1, number 2 insurance companies in most of our economies on the continent are doing very well, even though the insurance penetration is very low. So those numbers need to increase. I've been seeing some really interesting things in terms of insurtech, so technology-related access to insurance. And that's happening in a big way in the global north. There's no reason why it can't take off similarly in the global south. It also requires our insurance companies to be incorporating and integrating technology in a greater way in their own operations, because that allows you to bring down the cost and to better quantify, assess risks, and better price at that point. The second thing that I would say is, and I know here in the UK, this has now become a matter for the courts, where at first a number of insurance firms were saying, act of God. This is an act of God, and therefore this business interruption is not something that is covered by our coverage. And they have been taken to court. And now many of them are stepping back and saying, and they're admitting that they have liabilities to pay under the existing contracts, which is good. You know, I also feel we've entered a period of time where there is that which is legal and there's that which is moral. And there's far less tolerance from all of us to take a stand purely based on that which is only legal. We are more clear on the moral limits of what it is we will accept. And so I think it's good to see the insurance companies are being clear about the direction of travel they're going there.
And your third point?
Please, go ahead.
Your third final point.
My third and final point here is, I think the next wave of capital coming into Africa from an investment perspective is capital that is rather going to go into debt rather than equity. Equity, private equity is an industry, it's an approach that is based on the presumption of abundance, of growth. And our markets have been shaken to such an extent, our countries, our lives have been shaken to such an extent. This is no longer about growth. As one investor was saying recently, I'm no longer looking for a return on investment, ROI. I'm looking for a return of investment. Let me get back at least what I put into these businesses. And so the relationship of what does risk in Africa look like from a financing perspective has to fundamentally change. In the same way, it has to fundamentally change everywhere. And so the part of the issue in terms of financing healthcare businesses, they take a longer time to take off. They take a longer time to settle in, to institutionalize, to start to grow. And so as a result of that, I think investors who are seeking high returns as a consequence of the risk associated, the risk premium associated with Africa, need to rethink this. Fundamentally need to rethink this. And therefore, as a combination of more debt type instruments coming into the continent as opposed to equity will automatically allow you to reduce the return expectations. But equally, I think what cannot be excluded from these calculations anymore is with every investment that you're making into the healthcare space, and that is a lot more than just hospitals and clinics. It's diagnostic labs, it's insurance, it is health insurance, it's a number of things. We need to ensure that we are incorporating a calculation and a accountability against metrics associated with healthcare outcomes, with positive health outcomes. And I'll stop there.
Thank you very much indeed for that rich contribution. And thank you also for raising the issue of how we approach this issue, whether it's equity or debt, thinking now more about debt, recognizing that equity may have run its course, the need for us to look at risk in different ways. So very, very helpful. I've got an immediate question for you as we now move into this final 10 minutes of questions and discussions for everyone, but I've got one for you immediately, if I may, Geeta, from Mike Raxworthy, who asks, are angel funds or syndicates ever linked to incubators or accelerators in Africa? And would this lead to greater effectiveness?
The answer to that, in short, is yes. We have got more than 50 incubators and accelerators across the continent. Almost every single one of them will have linkages into this space. I recently been a member of an initiative that was set up by Jim Chu called the Nest. And we've gone on as venture capitalists so it's sort of a Dragon's Den type approach. And we've found great businesses that we're now diligencing, looking to put capital into. There are a whole bunch of initiatives, but the short answer to what you've asked is yes, it's happening, and more of it needs to happen. But now is also a time for us to pull our own personal checkbooks out as well. And knowing that actually the amount that you'd put into a holiday going somewhere makes a difference. You add that with a group of people, a few of us have started investing together as a club. It helps spread the work as well. We can all pitch in on the due diligence, and these numbers are meaningful.
Geeta, I think that last point, which you made also at the outset of your presentation, when you gave us these fascinating examples of life stores and 54G, I have never heard the challenge of what we can do individually with what small amounts of capital we have at our disposal. I have never heard it put so starkly or convincingly. And it leads me to believe that we need to do more work on this so that we are more readily aware of the opportunities that are out there. Because I don't think we are aware of those opportunities, and I don't think that there's a confidence that, yes, this is a group into which I can put 2,000, 3,000, 1,000 pounds. This is a fund into which I can commit £100 a month, or whatever it is. And I think getting the instruments and the institutional capacity in place to give that confidence, that would be a very valuable thing. And certainly, as Nick and Nicola and Jean have pointed us looking forward, This is an ongoing conversation, and I think you've started something very important there. Let's broaden the conversation out in the few moments we have left to us. I'm going to ask all our three panelists who've been so generous with their time to come in at the end for a final word. But before I ask them to do that, this is an opportunity to all our participants, a number of whom have been with us throughout these last this is the fourth, throughout the last three of the presentations. This is your opportunity just to make a comment, to put anything out there in the chat column, and then we'll put that to our panelists and they can respond if they wish in their last presentations. So this is a first and last call to you panelists. Get in there now. This is your unmute yourself, just get in there. Anyone that hasn't asked anything so far?
Yes, please, Paul, if I may. Thank you. Thank you very much to Geeta for her enlightenment on the situation in Africa. I'm in a current position which I would really value Geeta's comments and the other panelists. For example, I've worked for several years with UK universities on developing ideas, collaborations to help emerging economies and helping Africa specifically. And a few weeks ago, just before the COVID struck, I was contacted by one of my university partners saying, would I like to apply for global funding with them to support one or more of the projects that I have been working on for the last few years? And of course, I was delighted to hear that conversation. And I have, with them, been looking at different sources of funding in Europe, such as the Eurostar, Eureka funding. I have a meeting tomorrow, and I'm happy to share this. Medilink, which is a global association, if you don't know them, of medical enterprises, hospitals, university hospitals, and so on. And we have discussions tomorrow, and we've looked broadly at funding, at private-public partnership, and so on. And the general impression is that I can get anything up to 60% funding, which has always been a bugbear in the UK of trying to find match funding, especially for an SME. And we're looking at ways in which we can combine funding sources. I'd be really interested to know whether this is something of interest to yourselves as a project to find ways of matching funding, be it by, I've always in the past avoided angels and VCs and so on, only because it's complicated for an SME to get involved in that and giving away equity and all the other things. But now it's reaching a critical mass where I think there could be a way of doing this, which hasn't been available before. And people are more attuned to the need to invest quickly and develop in Africa and in Southeast Asia I'm working with as well. Sorry, that was longer, but I needed to just cover it.
Thank you very much indeed for that. Mariama asks, Geeta, what's the details for the nest? Trying to find them online. Well, if you can maybe answer that in chat. We're going to come to you in a minute. Are there any other questions, contributions, thoughts from any of our participants? If this is your chance. No. Okay, then I'm going to ask Agnes, would you kick us off, please, with your final remarks, thoughts, responses?
Thank you, Paul, and really thank you, Geeta and Dr. Fernandez, for your incredible contribution. Quick point, I think trade finance going forward and Dr. Fernandez, you talked about the importance of paying upfront. I think that would be almost impossible for a lot of our businesses, even in healthcare, to pay upfront for services. So I think we need to find a way of where we can make trade finance accessible for businesses in the region, particularly in the healthcare sector, who are struggling. I want to leave us with a joke. It's only a thief who wishes you to prosper in life, because a doctor wishes you're ill, a lawyer wishes you commit a crime so they can survive. And in this case, hearing Dr. Njoki talking is that doctors are overwhelmed, private practices are overwhelmed because they don't have patients. You know, I was wondering, should we be celebrating? Perhaps they're no longer ill. Should we be celebrating that we don't have a lot of sick people in Africa? But going forward, I think we see an opportunity, and I think government has a mandate. They have to pay it. And you're right, Gita, that the tax rate is very low, and therefore we cannot expect government to do everything. But governments have the primary responsibility to ensuring that we have a lot of resources. We're so rich, yet we're so poor. Surely we can afford to protect our citizens, to ensure they access health that is affordable and of quality. Thank you.
Thank you very much indeed for that. And one should always recall that it's not actually the rate of tax, it's the inefficiency of the collection model and the lack of a broad base for taxation. There are plenty of people that should be paying tax who aren't paying tax, even at the low rates, and a failure on the part of Inland Revenue Services actually to collect. But an important point about our collective responsibility. So thank you very much indeed, Agnes, for reminding us of that. We're going to have the final word actually to come from Kenya itself. So before we get to them, before we get to Dr. Fernandez, I'm going to ask you, Gita, just to have a final reflection on what you've heard and anything you'd like to share.
You know, in these days, there's so many things that we're facing at an unimaginable scale. And it's important, I believe, to do something everywhere we can. And that starts with angel investing, going all the way up to VC and holding our governments to account, but also recognizing that we need to be part of the solution. Yeah. And we know that we live in what is, deeply visible, unjust times. But the economy is actually that critical ether that's binding our engagement with each other. But then here's the thing, we are economic actors in it. And as such, social justice and the balancing of inequality requires all of us to remind ourselves of the purpose of capital. So when I think about this discussion about how do we finance and the role of capital, we're in a new era. And that is of working on resilience and preservation of existing systems, as opposed to trying to significantly expand them. So expectations of growth are nice, but less of an expectation for me right now. And the last thing I'll just say is money is sometimes just money, but investment capital is a whole lot more than money. And it's bringing in those linkages, which are really important.
Thank you very much indeed for that, and the reminder of the importance of investment capital, patient capital, sometimes from government concessionary capital. I think that's an issue that we need to return to, how we ensure that we address market failure through concessionary capital that's focused on creating jobs and opportunity in the sector, as well as delivering on those important health outcomes. This is
interrupt, if I may. Yep. We've had a final question come in on the chat from Kunal Patel, one of our speakers actually last week, who's asked what can be done to accelerate budget execution and fund release to the front line. So yeah, leave that for the speakers to come back to, perhaps. Right.
Well, an immediate one from you, Gita, and then I'm going to ask Agnes before we go to Njoki in response to that question. Any thoughts?
Yes, I actually came back with two quick questions just to get a bit of a context, which is whose budget and where? This question is a very, very broad question. I'd love to try and help answer that. I'd love some more context, however. And I don't know, Kunal, if you'd be able to provide that.
Right, let's give him a moment to think. Agnes, any immediate response?
So my thoughts would be, immediately cut the red tape. There is a lot of bureaucratic processes with government, and when funds are supposed to go to healthcare, they go somewhere else. So I think cut the red tape and focus on what is priority, making sure that funds are available to health sectors and that there is transparency also in how the funds are devolved into the sectors. So transparency and cutting of the red tape.
Transparency is so important too as a counter to corruption and failed procurement. A very important point there, and that red tape that does get in the way. But I have to tell you, as someone who's had responsibility in government for public spending, some of that red tape is necessary to produce the accountability. I mean, this is the dilemma. But we are where we are on that. I don't want us to lose, because it's an important point. Whose budget and where? Who have we got any clarification on that? Because it's a
Well, Kunal's come back to us and added in the comments that it's one of the key questions that WHO is asking every nation as part of its health financing guidelines for COVID. So it's country and context specific, which means, of course, it's very broad. But
yeah, but I think it is worth remembering, if this helps you, Gita, in your response. I mean, I remember as someone who was in government and then a diplomat during this period, that in the early days of the AIDS pandemic, in a South African context, the budget was actually a private sector budget. It was Anglo-American. Then, and they took a lead because it was in their interest to take a lead, as well as being part of their corporate social responsibility. And then government budgets came in. So, I mean, so very often you are actually, it isn't one budget or the other. It's a shared responsibility. But Gita.
Yeah, I think that point is very, very well made. And I would add to that to say, and thank you for the clarification, Kunal. My perspective is trying to move at speed is really important, but you want to balance that with making sure that you're not putting money in places which are where it's going to disappear or where there's no accountability, etc. There's a duty of care on all sides here. So unfortunately, what that means is you double down on the existing paradigm. So I would say, what's important is to try and very, very quickly identify routes to deploying this capital, both within the public sector as well as the private sector. And that might be, for example, a national development bank. It might be a business association where members are already vetted. So you're able to then say, okay, and you negotiate with them. You negotiate with them on what performance looks like, because we have had way too many examples of funding that has been made available to banks to onward lend to groups which needed the capital. And you've had investors who are willing to give them the capital, but the banks have looked at it and said, well, I still need collateral. Yeah. Or well, it still takes me, 3 months to do a due diligence on you. And you have examples of where this capital has sat. Even though investors have provided it, it's sitting with the intermediaries for years. And that doesn't work either. So I believe that, you want to speed this up by working with trusted intermediaries, but you also need to negotiate what performance and non-performance looks like with these trusted intermediaries.
Thank you very much indeed for that. Agnes, do you want to come back on anything before I turn to Dr. Fernandez?
No, I think Gita summarized it perfectly.
Thank you very much. Dr. Fernandez, very rightly, the last word belongs to you in Africa, in Nairobi, on the front line at this time. Over to you.
Thank you. Thank you very much.
If you'd put your microphone near, great.
Okay, thank you very much. There was something that, I don't know, someone mentioned that people are not getting sick. It was Agnes, and that's not a good thing. I think we must remember that the healthcare industry is an industry that supports the economy as well. So we cannot celebrate when they are losing jobs and they're losing revenue and hospitals are shutting down, because those are human lives as well. In the same thing with the insurance industry, I think it was Gita who mentioned that they're not doing very well. And that should also be a cause of concern, because they are also supporting the economy as well. So we need to look at the sector in totality and all the people who are affected, not just looking from a patient perspective, because I'm a doctor, so I work in a hospital. If I get laid off, then there's a problem there. Let's remember that. And then let's individualize this conversation, because by the time we get to government to release funds, get into policy, time is moving and we don't know when the next pandemic will hit us. So let's be prepared as organizations, as individuals. Let's think about, what can I do for me? In Kenya, we have these circles. We like getting into these small groups. We call them chamas, you know. In our small chamas, what can we do to prepare for the pandemic in future? Microinsurance is there. There's so many small things we can do as individuals to make sure that when we have a crisis next time, we have some sort of cushioning as we leave government to deal with the big picture. At least, you know, our lives continue. And I hope this discussion, I hope someone from government is listening to this conversation, and they will take this forward. Thank you very much for listening to me and for organizing this.
Well, thank you for that, Dr. Fernandez. Thank you to all our panelists. A big thank you to Nick, to Jean, to Nicole from BOBAB and Medicus, who after all have made this conversation possible. It's an ongoing conversation. The pandemic has revealed flaws and vulnerabilities that we have known are there, revealed them starkly. It calls upon us to address these issues with new vigor, with an open mind, with a recognition of our own capacity as individuals to make a difference. We're all of us here seeking to make a difference. That's why we've had the level of participation that we have. That's why we've been blessed over this series of 4 with the panelists we have. That's why there have been so many people looking in on this after the conversations on YouTube. They'll be out there as a resource for some time hence. I'm happy to say that we have been fortunate, Dr. Fernandez, at the outset to have had participation from African High Commissioners in this series. We'll be reaching out to them and to policymakers globally in the coming weeks in order that they are able to access this rich and varied source of contributions from people like yourselves on the front line, engaged activists in defeating this global pandemic, and also, and importantly, raising the profile of the issue of the funding and delivery of healthcare on the continent, so that Africa may deliver on the potential that we all know it has. I love this idea that you shared with us at the end, Dr. Fernandez, of is it chamas? I think you called it, a small group of people coming together with a commitment, with a purpose, and then growing that group, focusing that purpose and commitment. So for all of you, to all of you, thank you for your contribution over the last 4 weeks. And here's to the next conversation and taking this struggle for healthcare in Africa forward. Thank you very much, everyone. Goodbye.
Thank you. Bye.